throughout the hearing. If you have testimony you wish to submit for the record, you may do so via email at testimony@council.nyc.gov. Once again, that is testimony@council.nyc.gov. At any time throughout the hearing, please do not approach the dais. We thank you for your kind cooperation. Chair, we are ready to begin.
Good morning and welcome to the city's fiscal 2025 preliminary budget for the New York City Department of Health and Mental Hygiene. I'm Councilmember Lynn Schulman, Chair of the Committee on Health. I would like to thank my fellow Councilmember Chair Lee for holding this joint hearing. I would also like to thank everyone who has joined us today and acknowledge Councilmember Darlene Mealy, and we're joined by Public Advocate Jamani Williams. DOHMH fiscal 2025 budget totals nearly $2 billion, which represents approximately 2% of the city's budget. This budget includes $1.2 billion for the city's public health services, which comprise $442.8 million for personal services and $773.6 million for other than personal services. In the preliminary plan, funding for public health was reduced by $120 million, while the headcount decreased by 202 positions. In addition, the plan includes a program to eliminate the gap of $26.8 million in fiscal 2025 that will certainly impact services and operations for the public health area. While the council is optimistic for Healthy NYC and its results, we are also wary about some reductions in DOHMH's budget and headcount. One program area, disease prevention and treatment, has 130 fewer full-time employees now than it had at adoption. It is concerning to see a reduced headcount in any program area, but this is the largest decrease in headcount in any of the program areas, followed only by environmental health with 42 fewer positions. We will also focus on DOHMH's vacancy rate. There are currently 344 vacancies in public health and 183 vacancies in mental hygiene, which is on top of the routine vacancy reductions that the city has seen. I want to make it clear that vacant positions do negatively impact agency's operation, especially in the health sector, and DOHMH must fill those positions to further improve the services that they provide. DOHMH strives to keep all New Yorkers healthy, despite the disparities that some New Yorkers face with their health. The life expectancy rate has been gradually declining in recent years, and while the COVID-19 pandemic played a role in this decrease, it was only one factor that affected the decrease. Diabetes, cancer, and maternal morbidity have always been issues in the city and are several of the disparities that will be addressed in Healthy NYC. Local Law 46 is an extension of Healthy NYC, and it requires DOHMH to develop a 5-year health agenda that will ultimately increase the city's life expectancy rate. The council looks forward to hearing strategies that DOHMH will roll out to raise the life expectancy rate beyond what it has ever been. Before we begin, I would like to thank the committee staff for their work, including Danielle Glantz, Florentine Cabor, Christopher Pepe, Sarah Sucha, and Manur Butt. I would also like to thank my Chief of Staff, Jonathan Boucher, and my Legislative Director, Kevin McAleer, along with my Legislative Fellow, Andrew Davis. Before I turn it over to Chair Lee, I want to thank Commissioner Vossen and his team for all your work on Healthy NYC and everything else to keep our city healthy. I will now turn it over to Chair Lee for her opening remarks.
Good morning, everyone. My name is Linda Lee. I'm chair of the Mental Health Committee on and Addictions and Disabilities Committee. So I just wanted to welcome all of you to today's hearing for the city's fiscal 2025 budget. I would also like to thank Chair Schulman for co-hosting this hearing with me, and I would also like to thank Commissioner Vassan, your team, everyone here who's here today. DOHMH's budget for mental health services alone is $748.4 million, which includes about $63 million for personnel services to support 683 full-time positions. The budget also includes nearly $686 million for other than personnel services. The mental health services that the city provides are immensely crucial to New Yorkers, but some important areas tend to slip between the cracks. We held a roundtable last month on the needs and concerns that mental health providers have, and youth mental health and maternal mental health were among the most concerning topics we heard, which is what our roadmap will focus on this year. Our youth need mental health services in their schools. Pregnant people need doulas and postnatal mental health care. During this hearing, we will examine DOHMH's mental health budget and how it addressed the needs of those in need. We will also review the fiscal 2025 program to eliminate the gap pegs, savings of $12.4 million to ensure that any reduction will not impact programs and services, especially now as we continue post-COVID recovery. Another service that the city should invest in is access to clubhouses. DOHMH released a request for a proposal in October 2023 to expand the total number of clubhouses in New York City. However, the RFP's guidelines will exclude several of our smaller clubhouses that have been serving the population in need. Clubhouse expansion is part of the Council's mental health roadmap from last year, and we are interested in partnering with DOHMH to increase the number of clubhouses in the city instead of decreasing them. And I understand that the totality and the number of people served in your new RFP proposal are higher, but I'll ask some questions later about the size of the clubhouses. Among other topics, I would like to discuss the Mayor's Office for People with Disabilities, which I know is not you all, and ensure that we are not cutting their budget. Last year, I brought up concerns about MOPED's budget. However, the preliminary plan reduced this office budget to be about 1/2 of what it was 1 year ago, and we're talking about an agency that serves 1 million people in New York City that have various different types of disabilities. So we need to make sure that those services continue as well. I would like to thank the committee staff, Florentine Cabor, Daniel Glantz, Sarah Suture, Christy Dwyer, for all of their hard work, as well as my staff as well. And I would like to we've also been joined by Councilmember Menon on Zoom, as well as Councilmember Ariola. And now I would like to introduce our public advocate, Jumani Williams, who has come here to testify as well.
Thank you so much, Madam Chair. As mentioned, my name is Jumani Williams. I'm Public Advocate for the City of New York. I want to thank Chair Schulman and Lee, and the members of the Committees on Health and Mental Health, Disabilities, and Addiction for holding this hearing today and allowing me an opportunity to give a statement. In any given year, more than 1 in 5 New Yorkers experience psychiatric illness, with low-income people of more color often unable to access any treatment or support. Barriers to effective care include a host of issues related to a lack of adequate insurance, stigma and discrimination, lack of access to stable housing, among others. The increased visibility and vulnerability of these individuals, compounded with a decrease in resources as cities around the country struggle to meet demand, have devastating consequences. The death of Jordan Neely last year, an unhoused person experiencing a mental health crisis on the subway, is just one example. Programs like Be Heard, launched in 2021 to address mental health crisis calls with non-police response, cover only 1/4 of mental health calls made in the city. Be Heard teams are established in only 31 of the city's 77 police precincts. One of the primary challenges has been hiring enough social workers and EMS staff for Be Heard teams at a time when EMS staff are already overstretched. The lack of adequately trained staff has led to continuous cuts to the program's budget. Peer support specialists and other embedded mental health infrastructure could help fill these gaps. The city's Overdose Prevention Centers, or OPCs, which opened in 2021, and in their first 6 months of operations helped prevent over 300 overdoses, is another program that could address serious health care gaps in NYC. I want to echo the Progressive Caucus' request last year for $20 million to shift the city's 2 existing OPCs in Manhattan to 24/7 operations and to open 4 additional centers, 1 in each borough that does not have an OPC. In addition to these requests, I want to highlight and reiterate my support for a few recommendations from my office's report, Improving New York City's Responses to Individuals in Mental Health Crisis, released in October of 2019. The report, updated and reissued in November 2022, was informed by conversation with and the work of mental health and justice advocates. I want to uplift the need for respite centers. They're an alternative to hospitalization for those in crisis and serve as temporary stays in supportive settings that allow individuals to maintain their regular schedules and have guest visit. Currently, there are 4 health department community partners operating respite centers serving adult New Yorkers, a drop from 8 centers in 2019. ACS also operates a respite program for youth, and increasing supportive housing. Supportive housing is affordable housing with a supportive social service in place. Currently, the city is lagging behind in providing supportive housing with a long and often delayed application process. This should include supportive housing for incarcerated individuals and individuals re-entering communities post-release. Further, I would highlight the need for expanded STI testing and sexual health care centers, and recent data from DOHMA shows that the number of sexually transmitted diseases has spiked across the city, with rates of chlamydia, syphilis, and gonorrhea skyrocketing across demographic groups. And finally, I want to highlight all the recent and planned hospital closures. Over the past 25 years, we've had a total of 20 hospital closures. These closures have disproportionately impacted communities of more color, who often bear the burden of adverse health effects. By closing hospitals, we are losing access to beds and precious resources, and we cannot afford to go backwards. The COVID-19 pandemic exacerbated health outcomes and further contributed to staff shortages and high rates of turnovers. It's our responsibility now to realize the reforms needed and act swiftly to prevent more suffering and loss. I look forward to engaging with this council, the Adams administration, including H&H, Department of Health and Mental Hygiene, and communities across the city to address the issues. The last thing I wanted to mention was that yesterday the NYPD mentioned the need for the type of overtime dollars that they have to address issues. And as an agency, I understand agencies wanting to make those asks. I don't know if I'll be here to ask questions, Madam Chair, but I would like to know if DOHMH has the same access to overtime they think they need to address mental health issues that arise when the city needs it. Thank you.
Thank you, Public Advocate, and I'll leave that to Chair Lee when it comes up for her to ask questions. So I'm going to start with the questioning, Commissioner. So, and I'm going to ask about Healthy NYC first. Favorite? Oh, that's right. I'm sorry. Sorry. Yes. We're a little discombobulated today. I'm so sorry. Give you testimony.
Sorry, Chair.
Should I be sworn in, maybe?
Good morning. Good morning, Commissioner. Right here.
Hello.
Hi, good morning. If you could please raise your right hand, you as well. Do you swear to tell the truth, the whole truth, and to respond honestly to council member questions?
Yes.
You may proceed.
Okay. Good morning. Good morning, Speaker Adams, Chair Schulman and Lee, Mr. Public Advocate. I'm Dr. Ashwin Vasan. I'm the Commissioner of the New York City Department of Health and Mental Hygiene. I'm glad to be here today. Joined by our Chief Financial Officer, Aaron Anderson, and members of our senior leadership team. Thank you for the opportunity to testify on the department's preliminary budget for fiscal year 25. I want to start by acknowledging the Speaker's State of the City address last week. We are so grateful to have a Speaker and a Council focused on areas that are important to New Yorkers' health and well-being, like youth mental health, maternal health, and chronic disease prevention. It's certainly been a busy year. The Health Department continued to manage COVID-19 through the end of the federal public health emergency, while defining a new strategy and ambitious goals for healthier, longer lives. Last November, we launched Healthy NYC, an ambitious citywide strategy to improve and extend the lifespan of all New Yorkers by addressing the leading causes of death and premature death. We know COVID-19 took a major toll. In 2020, the city saw the biggest and fastest drop in lifespan in a century, dropping 4.6 years to just 78 years. This was the largest drop in our history and the largest drop anywhere in the US or the world in 2020. In encouraging news, though, the city gained back 2.7 years in 2021. However, aside from COVID, the leading causes of death of New Yorkers are moving in the wrong direction. And like in so many issues, the decreases in life expectancy have not been experienced equally. The largest decreases were amongst Black and Latino New Yorkers, with the disproportionate burden of premature death, death before the age of 65, falling on these communities. These are also the deaths that, of course, contribute most to life expectancy loss. To address these declines, the Health Department and this administration have advanced the implementation of Healthy NYC to increase the life expectancy of New Yorkers to its highest ever level, 83 years, by 2030, with equity at the center of all of our work. To achieve this goal, we have set very specific targets to reduce mortality from the leading issues killing New Yorkers: chronic and diet-related diseases such as diabetes and heart disease, screenable cancers, mental health, including overdoses and suicides, and violence, including gun violence. Healthy NYC also sets targets to address COVID-19 related deaths and the unacceptable disparities in Black maternal mortality, while addressing cross-cutting issues, including access to health care and the impacts of climate change on health. If the city is successful in reaching each of these targets, we will not only achieve a life expectancy in New York City of 83 years or more, we also estimate that we will stop well over 7,000 preventable deaths. That's 7,000 mothers, fathers, siblings, friends, and loved ones who would otherwise be taken from us too soon. Ultimately, Healthy NYC is an organizing principle toward a future where New York City is the healthiest big city in the nation and the world. Too often in government, we are afraid to set big, tangible, measurable goals and to hold ourselves accountable to them. Instead, we set smaller ones, maybe ones that are easier to achieve in a few months or a few years. But complex, long-term challenges, like improving the health of our city, requires long-term vision and near-term action towards that vision. It requires everyone pulling in a common direction, not one agency alone, but one city. We will get there by investing more in prevention and upstream care, earlier intervention and support, and ensuring access to services that meet New Yorkers' health and social needs. And we will get there by responding with intentional action and planning and repeating this year after year. Healthy NYC is the first of its kind agenda in the city and in the nation. I am grateful to the mayor for his support and proud of my team for building out this campaign and working together to organize our city around these goals. I'm grateful to my fellow commissioners and city leaders who continue to endorse and embrace this agenda, and to our partners in the nonprofit, private, and philanthropic sectors who continue to engage with us. I also want to thank the New York City Council, particularly the Speaker and Chair Schulman, for enshrining in local law the requirement for the city to ensure that this work will endure, that Healthy NYC will endure for decades to come and will not be subject to the whims of electoral cycles and political cycles. The health of New York is foundational to New York City and our world. There's no wealth, no prosperity, and no equity, and no safety without health at the core. The Health Department also remains focused on addressing the second pandemic of mental health issues. As we would say in medicine, this crisis is acute on chronic. We had growing mental health needs long before COVID-19. Mental health systems were chronically underinvested in, and the pandemic was an acute stressor that made everything worse. Last year, we announced a comprehensive mental health plan to alleviate and prevent emotional suffering and to save lives. This plan will continue to guide the city's future actions to improve mental health. The Health Department has executed on several commitments in our plan in the last year. Importantly, we transitioned NYC Well to 988 to ensure that these 3 digits become the go-to resource for all New Yorkers for mental health concerns and for crisis response. We launched NYC Teen Space, the city's pioneering no-cost digital mental health service available on mobile devices to all New York City teenagers between the ages of 13 and 17. I'm pleased to report that after just 5 months, we have seen thousands of teenagers sign up. Moreover, this fiscal year, we distributed more than 280,000 naloxone kits, expanded our emergency room peer-led overdose response program, supported syringe service providers in all 5 boroughs, increased access to buprenorphine in primary care, emergency departments, and in harm reduction sites, and in homeless outreach settings, and much, much more. Finally, in early 2024, the Health Department and the Mayor made 2 key announcements that will have important impacts on thousands of New Yorkers. First, we will invest $18 million over 3 years to relieve over $2 billion in medical debt for hundreds of thousands of working-class New Yorkers. Throughout my career as a doctor, I've seen firsthand how high healthcare costs and medical debt can force patients to make impossible choices. And as we all know too well, medical debt is the #1 cause of bankruptcy in the United States and disproportionately affects uninsured, underinsured, and low-income households. The city's program will wipe out medical debt for up to 500,000 working-class New Yorkers. Second, the city set out to address the mental health impacts of unregulated social media on our youth. This included a commissioner's advisory declaring social media an environmental toxin and a historic lawsuit against 4 of the largest social media platforms. As a parent, I want to keep my children safe, and that includes the use of interaction with social media. This administration and this health department are committed to leading on this issue. And there's so much more. As New Yorkers, we know that everyone deserves the right to make their own healthcare decisions and to control their own bodies. New York City has continued to lead, ensuring that our city is a safe haven for reproductive health care and abortion access. Over the past year and a half, the health department has expanded medication abortion access in our public health clinics, the first in the nation to do so, and have strengthened the abortion access hub, which ensures anyone from anywhere in this city or country can access reproductive health care in New York City when they need it. We've also strengthened the department's internal capabilities, including our data systems, by building the new Center for Population Health Data Science to bring together health and social services data into a single view to enable citywide planning for New Yorkers' health, and to ensure resources and services are getting to the communities who need it most. The department has also started a response readiness initiative to ensure we're better prepared for the next health emergency, whatever or whenever it might be. And the department has invested in our staff by expanding our worksite wellness programs and by centering mental health in the process. Our most recent workforce survey shows that more than 75% of our health department staff are satisfied with their work at the agency, a significant increase from past years when morale was low in the face of crisis and constant attacks on our work. Before I talk about the budget, I want to take a moment to thank my team. And that includes those here with me today, my senior leadership team and the staff who helped prepare for this hearing. It also includes those back at our offices and those on the ground running everything from public health clinics to health inspections, community health work, and disease investigations. My colleagues make me so proud to come to work every single day. We continue to do this work because we are here to save lives, to prevent suffering, and to ensure that every New Yorker can live a healthy life. Public health is often an invisible shield, stopping bad things from happening before they occur, and responding when they do. But even if our work is invisible to some, every single employee of the Department of Health deserves recognition and thanks for a job well done. Now, I'll take a few moments to speak to our preliminary budget. The department has approximately 7,000 employees and an operating budget of $2 billion for fiscal year 25, of which approximately $1 billion is city tax levy. Over half of our budget is comprised of federal, state, and private funding. We are pleased that our preliminary budget continues funding for many of the agency's priorities and allows us to execute on activities to address the goals we've laid out in Healthy NYC. We look forward to answering your questions on our preliminary budget. Now I'll turn to the state budget. The governor's fiscal year 2025 executive budget proposes significant investments in mental health, maternal health, and the well-being of children and families. These investments all align with the city's Healthy NYC goals. On mental health, the executive budget seeks to improve access to mental health services by raising the minimum reimbursement rate for commercial providers. I am pleased to see the Senate has included this in their one-house budget and urge the Assembly to accept this policy. The executive budget also includes the Stop Addictive Feeds Exploitation, or Safe for Kids Act, which is an ambitious first step in regulating social media companies and complements the city's work to address the health threats posed by social media. Unfortunately, the state legislature rejected this language. I urge them to pass this as part of their final budget. The department supports other actions in the executive budget that are there to support maternal health. Governor Hochul included language establishing paid prenatal leave for medical appointments. The Senate and the Assembly have versions of this in their budgets, and we hope they can resolve their differences. The budget also establishes a statewide policy which will allow all birthing people to access doulas, as well as includes language providing for breast milk expression breaks. Unfortunately, the Assembly omitted these items from their bill, and the department strongly urges them to reconsider. We also firmly support investments in child and family health established by continuous Medicaid enrollment for children from birth to age 6. We are pleased both houses have included this vital policy. The governor's budget demonstrates a commitment to public health and health equity. However, the budget fails to address a key issue which undermines New Yorkers' health, gains in health equity, and our core public health infrastructure. It is not acceptable that New York City continues to be denied its fair share of public health resources from the state. 5 years ago, New York State cut Article 6 public health funding to New York City from a 36% match on the dollar to 20%. This cut was to New York City only. At the time, the justification was that the city receives funding directly from the federal government. But these federal funds are for specific issue areas, not for general public health support. If parity was restored for Article 6 funding, we project the city would receive an additional $90 million to support critical public health services. These are funds that can be used to address rising rates of vaccine-preventable diseases, sexually transmitted infections, and tuberculosis, many diseases that we thought we had relegated to the past, as well as the growing crisis in overdose rates and Black maternal health. These amongst other essential and mandated public health services. New York State has an obligation to support the health of all New Yorkers, including those who live downstate in the 5 boroughs. At least 50% City. And most of the people of color and low-income people in the state call New York City home. This is a health issue, this is an equity and racial justice issue, and it is an issue of basic fairness and good governance. This means that New York City must be funded at the same rate as every other county in the state. Today, I'm asking all of you to urge your state colleagues to reinstate New York City's Article 6 reimbursement in the state's adopted budget. Finally, I'd like to make a few comments on the federal budget. We thank President Biden, Leaders Schumer and Jeffries, and the New York congressional delegation, and Health and Human Services Secretary Becerra for their consistent support. We are, however, concerned with budget cuts for critical, federally supported public health services and infrastructure. Federal funding makes up almost 20% of the Health Department's budget. The Health Department has long expressed concern about the federal government's continued cuts to the Prevention and Public Health Fund and the Federal Public Health Emergency Preparedness and Hospital Preparedness programs. It's essential for the federal government to focus the necessary attention and resources to ensure the country has a robust health security infrastructure that can meet the scale and scope of threats we face in our rapidly changing world. Additionally, while we are all grateful COVID-19 is no longer an all-hands-on-deck emergency, the federal funding that boosted so much of the response has expired with the end of the federal emergency. This loss of supplemental funding is impacting our disease surveillance and response infrastructures well beyond COVID-19 work. We are in a critical moment with federal and state investment in public health. As I previously mentioned, over half of the department's budget is from state, federal, and private funding. We must learn from the lessons of the last 4 years and ensure that there is strong investment in public health infrastructure by our state and federal colleagues. We invite the Council's partnership in advocating for more state and federal investment into public health. I know many of us are fatigued of thinking about the public health emergency, but ignoring and disinvesting in public health only makes us more vulnerable to the next threat. So as I wrap up, I want to thank the Health Department staff once again for their steadfast commitment to the health of this city. I look forward to continuing to work arm in arm with them and with you to improve life expectancy through Healthy NYC and to face our public health challenges head on. I thank Mayor Adams for the resources dedicated to this department in his preliminary budget. I thank you, to the Speaker, to the chairs, to the members of the committee for your partnership and dedication to the health and well-being of all New Yorkers. And now I'm very happy to take your questions.
Thank you, Commissioner. So first, I want to acknowledge we've been joined virtually by Councilmember Caban. We're joined in person by Councilmembers Abreu and Feliz. So I'm going to ask you some questions. I'm going to start easy and then get harder, like Proud Mary. So, in 2020, due to the pandemic, the city's life expectancy dropped from 82.6 years to 78 years. The council passed Local Law 46, which would require DOHMH to develop a 5-year health agenda with the goal of increasing the average lifespan of New Yorkers to 83 by 2030. This is part of the Healthy NYC campaign to increase the city's life expectancy. And what fiscal year will funding for Healthy NYC be included in DOHMH's budget going forward?
Thanks, Councilmember, for the question. Healthy NYC is, of course, subject to investment, but it isn't a program like any other. Right. It is very much our strategy. It's our North Star. It's the framework under which all of our work is done. In fact, we have not only set these goals out for the public and for our external work, but we've realigned our agency and our internal performance and our KPIs to align with this. So it's much, much more than just a line item in a budget. We are obviously looking towards the kinds of investments we need to build a program around it as well. But this is about really achieving our Healthy NYC goals with leadership from all of our divisions throughout.
And is there an operating budget, or for Healthy NYC?
Yeah, we're still working through those details.
And when you have that, please share it with us. We'd like to help with that. So
happy to.
What funding sources will be used to fund Healthy NYC? Again, same thing, I'm assuming. Okay. Have there been discussions with our state or federal counterparts regarding Healthy NYC?
Yes, they're well aware of this and very supportive. In fact, we've had discussions about these goals with both federal counterparts and state counterparts, and that's particularly interesting and important as we consider new initiatives like the Medicaid waiver, and where does the Healthy NYC goals align with our downstate goals in terms of health and health equity. So we're in active discussions now.
Okay, so diabetes is a major health concern, one that can result in multiple lifelong health conditions. The PMMR states that diabetes management has increased slightly among adult New Yorkers. The goal of Healthy NYC is to reduce the prevalence of diabetes in the city by 5% by 2030. How many people in the city currently have diabetes in calendar year 2023, and how does that number compare to the last 5 years?
Thank you for the question. I'm happy to get you specific epidemiological details, but I will say that, yeah, by 2030, it may on its surface not sound like a large goal, but disease deaths stay extremely high as the leading cause of death of New Yorkers, and we've struggled to make a dent. And part of the reason we've struggled to make a dent as a society is that our society is perfectly set up to create diabetes, whether it's processed foods, poor diets, lack of green space for activity. So these are all areas that we are focused on, as well as connections with our healthcare systems who do so much work in both screening for diabetes early and ensuring that people get evidence-based care. One of the things we're most proud of with our diabetes work is that we have the largest diabetes prevention program in the country, which means we bring together community stakeholders to really advance what better lifestyles look like, what better health looks like. And we're also very excited about our Public Health Corps program, which puts community health workers into high-need neighborhoods and advances health coaching, lifestyle change, and connections into primary care, amongst other things.
How many people have passed away from diabetes in 2023, and how does that number compare to previous years, if you have?
I'll happy to get you the epidemiological details.
And strategies you kind of went over. Hold on 1 second. What is your current 5-year timeline to ensure that this goal is reached by 2030?
So we're very proud that we're in the midst of and approaching the end of a citywide chronic disease prevention task force, which has convened all city agencies around our Healthy NYC goals, both for heart disease and diabetes, as well as for screenable cancers, because we know the same risk factors are associated with the development of many diet-related and other related cancers. So we will be publishing a full strategy, but it really focuses on the use of place-based strategies, especially leaning into community health workers, the saturation of high-burden neighborhoods with evidence-based group interventions like the diabetes prevention programs, added support and connection to our safety net primary care facilities, partnering with H&H, but the many, many FQHCs and safety net providers around our city, and making sure that we invest in health-related social needs and nutrition security, as well as addressing the commercial determinants of health and really looking at the role that industry plays in shaping our diets, our activity, and our exposure to unhealthy foods.
Do you believe that the goal is realistic for diabetes?
I believe it is, yes.
Okay, so if so, what is your ultimate diabetes reduction goal past 2030?
That's a great question. You know, as I said, we haven't set that goal out beyond 2030. Obviously, we want to get that number as low as possible. What we want to show with this goal of a 5% reduction is that we can actually act in coordinated ways as a city. You know as well as I that we are so siloed as a city, as a state, as a country. And what we did is this is not just the Department of Health's plan, this is the New York City plan and the administration's plan and the cross-administration plan to improve health, because we need everyone pulling in the same direction, whether it's our healthcare systems that the city runs, healthcare systems that are private and nonprofit and academic, and also community organizations, as well as city agencies pulling in the same direction.
Last year, the council passed Local Law 52 of 2023, which would require DOHMH to develop and implement a citywide diabetes reduction plan. By April 1st, DOHMH should have a plan to identify a goal percent and timeline for the reduction of diabetes cases, and I understand this overlaps with Healthy NYC. Include strategies and timeline for the reduction of diabetes cases include strategies that the department will use to reach these goals and post those findings in a report on their website. What's the status of the report?
We are analyzing that data now, and we are on track to finalize the diabetes incidence and reduction plan, and the data for this report is on track to be submitted in the coming weeks.
It's like a week, just FYI.
We're on track.
Okay. Have you had any challenges in preparing the report?
It's always challenging in bringing together data in this city. As I said, we are a siloed city. We have siloed data. And that's why we built our Center for Population Health Data Science, to create a single data hub for our city where we can bring together health, social services, community, institutional data and match it, and then do citywide analytics. We've never had anything like this. You'll all recall that during COVID, like me, the first place I went to every morning was the DOHMH webpage to look at the cases. That was the result of data coming from every single health facility, every single lab facilities, even community-based programs. And that was built on the back of my staff working overtime, extra days, 7 days a week, 18, 15, 20-hour days. That's not sustainable. And in an era of technological advancement and AI and advanced informatics, we should not accept as a city that we have these data silos. And so that's what we're building with the center.
No, I appreciate that, and we're trying to do what we can to be helpful to you in that
We're
regard.
appreciative very much.
How does the diabetes reduction plan relate to Healthy NYC's goal to lower diabetes cases?
Yeah, it's one and the same.
Okay, great. So I'm going to ask about rest in peace debt. A couple of questions. The medical debt relief program. So, as you indicated in your testimony on January 2nd, 2024, DOHMH announced a medical debt relief program that would invest $18 million over 3 years to relieve $2 billion of medical debt. And I just want to make a comment that that's actually the largest program in the country, because other states have announced programs and said, oh, they're wonderful and this and that, and they're a fraction of what this is. So I want to commend you for that. This is a one-time program that will launch soon and run for 3 years. When will the program begin?
We're in discussions now with RIP Medical Debt to organize the program and to make sure that we have data access. And the amazing thing that RIP Medical Debt does is really bring together data that you have to have very specific knowledge to understand. You need to understand actuarial tables and insurance data, and they have it because it was an organization built by two former insurance executives. And so they understand hospital billing and payment really well. So we're working with them closely to finalize the details of that contract, and we should be getting off the ground.
Can you tell us what the eligibility criteria for the program is?
Yeah, I'll get you very specific information, but it is related to the federal poverty line or the percentage of income that debt represents in your household. So, but it does vary by individual or family, so I'll get you the details.
Now, is this funding housed under DOHMH,
Yes.
H&H, or DOHMH?
Yeah,
Okay,
it's our
great.
fund.
And so DMH, I'm going to go on to something else. DOHMH's headcount in the preliminary plan for fiscal year 2025 is 196 less than its headcount in fiscal 2024 at adoption. The program area with the largest difference in headcount is disease prevention and treatment, which has 130 fewer full-time budgeted employees in fiscal year 2025 than it did in fiscal year 2024 at adoption. DOH's overall headcount was impacted by a PEG reduction of 18 positions in fiscal year 2024 and 2025 in the preliminary plan, and 29 positions in fiscal 2024 and 2025 in the November plan. Were there any headcount reductions in the disease prevention and treatment program area between fiscal years 2024 and 25?
Yeah, thanks for the question. So just to be clear, that number 196 doesn't account for grant lines.
Okay.
So many of those positions are actually grant funded. But as you know, in the prelim budget, it doesn't represent federal grants at this stage because of the fiscal year cycles. 47 of those 196 were from the November and January plans, which represents about 24% of the total vacancy reductions, not inclusive of grants, of course. Those reductions, we took every effort to ensure that they were spread throughout the agency so that one group didn't face a disproportionate burden.
Yeah, you can understand my concern. The disease prevention and treatment is at the heart of Healthy NYC, so we want to make sure that you have the positions that you need to undertake the program.
Thank you.
So, sexual health clinics. I understand recently a number of sexual health clinics across the city have closed. How many have closed? How many sexual health clinics have closed?
Well, actually, we've reopened several. Okay. We have 8 sexual health clinics across our city. 6 of them are open, only 2 are closed, and we've been able to reopen them, and we're working hard to get the final 2 reopened as well.
What are the challenges there in reopening them?
You know, as you can imagine, we face challenges with labor markets and salaries. We face challenges with hiring. You know, and we've had long-term challenges with our sustainability of our public health clinics, but they represent a critical part of our public health infrastructure, and we are very much committed to them. I know OMB is also very much committed to them, and so we're grateful for that partnership, and we continue to work on a long-term plan for sustainability.
So 2 questions I have. Which ones closed, and why did they close?
They didn't close, just to be clear, they didn't recently close. They've been closed.
Right, no, understood.
I believe it's Washington Heights and one other, but I'll get you the details.
Okay, so I want to ask a question that we kind of has been asked in the past about the public health library, if you recall that issue. Mm-hmm. So the William Halleck Park Memorial Public Health Library, located in Long Island City, had for decades provided DOHMH epidemiologists and the public with access to peer-reviewed medical and public health journals, databases, books, and other research materials on-site and electronically, as well as via loans. Unfortunately, DOHMH closed this facility to the public and canceled its medical journal and database subscriptions last year, citing budget cuts. At a time when our city is recovering from a global pandemic, we should be prioritizing access to the latest medical research to better inform the city's public health strategies. Was DOHMH, who ordered the closing, and what is being done to sustain that level of research?
Yeah, as someone who, you know, has an academic background, or at least partly an academic background, and continues to maintain an academic appointment, it's very important to me that my staff have access to the latest academic research in order to inform evidence-based public health programs. We're very proud of the Public Health Library. I just want to be clear, it was never really designed to be public-facing. Right. It was designed to really serve our staff, and so while we've had to make difficult decisions in the process of these PEGs, we have taken pains to ensure that we maintain access to key research for our staff through other means. I will say this. This is part of a broader trend of the cost of journal access. I mean, we're seeing even universities cancel journal subscriptions due to rising costs of journal access, and it's becoming somewhat unsustainable to continue to pay these higher and higher prices. In fact, over the time of the existence of the Public Health Laboratory, the budget has had to fund fewer and fewer journals because the cost of each journal is going up. And so we've been discussing at length with our academic partners in the city, particularly the academic schools of public health, and we'd really encourage them to step into this with us. They have access to all of these journals, and we work already extremely closely with them. We'd like to build on that partnership with them and to rebuild this service.
Well, you mentioned there were other means. What are the other means that are being used to access the research?
Well, a lot of it is finding resources to fund priority journals, to essentially make choices, tough choices, but really asking our staff what's most important to them in terms of research access. And so we've tried to maintain some of that, and increasing our academic partnerships. Many of our staff have voluntary, zero-salary appointments at academic institutions across the city, and we're really leaning on our academic partners who, have a lot of resources to help us in this effort.
Are DOHMH staff paying out of pocket to access subscription-based public health research?
No.
Okay. What is the cost of the health library on an annual basis?
We're happy to get you budget.
If you can get me the budget number, because we can see if there's anything that can be done on the council end. And I have one other question before I hand it over to Chair Lee, and I also want to acknowledge we've been joined by council members Hanif and Zhuang. And Bacher. And Marmorato. Here you are, sorry. DOHMH intends to award a contract to Lifeguard Digital Health for the Lifeguard Light Pilot Program, which is a physical timer that can be activated to self-monitor drug use. Residents can set the timer for a couple of minutes at a time or manually turn it off, and if they don't respond to the prompts, an alert will be sent to check on the resident and alert 911. Can you provide additional information on this program?
Thanks for the question. Yeah, we haven't awarded anything yet. We're just in early stages of exploration and procurement. But you said it yourself. We are in an overdose crisis. Mm-hmm. We're losing a New Yorker less than every 3 hours to a fatal overdose. Those numbers continue to increase quarter on quarter, year on year. And I struggle to understand why people are fighting between different solutions when we are losing this fight. We have to have an all-hands-on-deck approach. We know that the vast majority of overdoses happen alone, in housing, when people don't have access to help and they can't call for help. So Lifeguard is an evidence-based program that has been used in Toronto and British Columbia, and we're piloting it here. We are always open to trying innovative approaches to save lives because we are losing this fight. We don't have time for petty arguments around which approach is better, especially petty arguments that aren't grounded in evidence. And I feel very strongly about this issue because we spent too much time fighting over which approach is better than another because of politics and because of, frankly, personal views on stigma and discrimination against people who use drugs. We need to save lives. People are dying. And I expect the council, and I hope the council and everyone else will sort of band together and try to join us in this fight. And we're going to try everything we can.
Can you tell me what the funding source will be, or are you still working that out?
We're still working all the details out.
Okay, when you have that, let us know too, because obviously that goes to the budget of the agency.
Yep.
With that, I'm going to turn it back over to Chair Lee. Thank you very much.
Thank you. So I'll use the same approach as Chair Schulman, where we start easy and then do like a little musical crescendo and then go back down. So, but wanted to start off with a couple things related to what was addressed in the speaker's State of the City, which are the next stops of the roadmap that we want to address. More specifically, wanted to start off with youth mental health services. There is a lack of focus on youth mental health, and I think many parents, including the ones I know at my son's schools, they don't know the specific services that their children's schools provide. And there are also concerns about schools receiving budget cuts, which will force social workers and clinicians to do additional jobs on top of their regular duties, which I know happens at my son's school because they technically have a social worker and guidance counselor, but then because of, cuts, they're sort of moving them around within the school system. So what is the current budget in the fiscal 2025 preliminary plan for youth-specific mental health services, and how does that number compare to the budget during adoption?
Thank you for the question. We're happy to get you specific budget details for that area of work. It is a priority for us, and I'm sorry to hear that you believe that it isn't well understood. I will agree with you that this is a hard area for all parents. I'm a parent, and I have had to seek mental health services for my own children, and it's really hard. And so I empathize with everyone facing this challenge. We have made this a priority in a few ways, both within school and outside of school, and in partnership with the state. We're very happy that 5 new school-based mental health clinics were opened in 2023. There are another 25 pending and expected to be licensed. Obviously, licensing happens by the state. That is a big expansion, and we're grateful both to the governor for additional resources, but also we've made a commitment in this space as well. But we hear you, and we heard you on this issue, and we've heard this issue for a long time, that school administrators are saying it's very challenging for us to do this on top of our day jobs of teaching our children and keeping them safe. And that's why we built Teen Space. That's why we built a self-empowered digital mental health platform in the palm of the hands of, up to 400,000 New York City teenagers, ages 13 to 17. At least that's the universe of who can access it. And that program allows them to self-direct their care, to normalize the act of asking for help, to actually receive help when they ask, and to do that independent of a teacher or an adult or anyone else in between, to basically bring the front door of our very complicated mental health system to the people who need it the most, our teenagers, our young people. And so as I mentioned in my remarks, we're only 5 months in. We'll be putting out some preliminary evaluation data in the coming months, but we're so excited that it appears that not only thousands of students have signed up, but that they are, the majority of them are coming from low-income neighborhoods, from neighborhoods that are mental health professional shortage areas, and they are coming from our TREE neighborhoods, the Task Force on Racial Inclusion and Equity neighborhoods. So we're getting to the right, most vulnerable children, in addition to expanding access to all children if they should choose it. And so I ask everyone to really disseminate Teen Space, talk about Teen Space, empower our young people to ask for help and normalize it.
Thank you. And to your point about silos, which is also one of my pet peeves in government, is all the different silos that we have. Thank you for that, because I know that some people may go to the DOE site first, some people may go to the DOHMA website first, so depending on that, hopefully they'll be able to get to the same place in terms of what services are available for their kids. And speaking of Teen Space, can you go into a little bit why, because I know that there's a ton of nonprofits that are also in this room and partners that we have that do a lot of peer services, as well as programs in schools, after school programs. And so just wondering what the rationale was in terms of how you chose Teen Space, because it is a for-profit company, and why not utilize also and incorporate some of the community partners that we have already here?
It's not a choice between one or the other. Teen Space is a very specific intervention. And it's built by an organization that has those very specific skills. Our nonprofits don't have those technological skills. I ran a community-based mental health nonprofit for years prior to becoming commissioner. We did not have those skills, and we were one of the better, stronger, more well-resourced nonprofits in our city. So with forgiveness from all of my nonprofit brothers and sisters, we just don't have those skills in technology and innovation and digital health. We just don't. But that doesn't mean we aren't also partnering with our community-based providers, our Article 31 clinics. All of those school-based mental health centers that I described are run by community providers. They're not all run by big health systems. And so we believe strongly in a both-and approach. It's not one or the other. And
so is there opportunities then for some of these nonprofit folks to get trained in how to, and making sure that they're aware of Teen Space and how that connects with the work that they're doing on the ground?
Yeah, I mean, the contractor, the vendor, has done a good job of marketing so far. we will continue to market this in everywhere and anywhere we can so that we increase enrollment,
Okay.
including our nonprofit.
Okay. The mental health continuum is a cross-agency partnership between DOHMH, DOE, and H&H to provide mental health support to students. What is DOHMH's current role in the mental health continuum? And what is the budget, as well as how does DOHMH partner with DOE and H&H to provide those services? Because I know that's a huge,
Yeah, it's a
important
big
program.
question. We're happy to get you details on the budget. I would say that the mental health continuum is really focused on children with severe and extreme emotional disturbance and need. And so, as you can imagine, those children need clinical care or psychiatric care or at least advanced psychological care, and most of that is run by our health systems, H&H specifically in this program, and so they take on the disproportionate share of that work in the mental health continuum.
Okay. Is there a focus, and this is one of my, and I know some of my colleagues share this priority, about hiring bilingual clinicians or clinicians that speak multiple languages, which I understand we're at a dearth to begin with. There's very few of them. We need more, and we need to build that pipeline. But the ones who are bilingual, what is the effort that's being made to hire those clinicians, and also which languages are being prioritized, and what languages are the most challenging to hire for?
Oh, we can get you details on the languages. I mean, language access is such a huge issue. We are obviously committed to it as an agency. We expanded language access during COVID to beyond the sort of 33 recognized in New York City, but it's a huge issue in mental health specifically. What we've tried to do is recognize there is such a dearth of providers and really trying to expand cultural competence. One of the ways we've done that is through our API-focused programs promoting mental health in AA and HPI communities, where we've developed a curriculum to work with community providers and to work with communities to break down stigma and discrimination, but to also increase cultural competence. And language is a big portion of that. And so we've partnered with 10 AAPI serving, AA and HPI serving organizations around our city. And it's a start. It's not sufficient, but it's necessary, and we're just getting started in that space.
Okay, great. In the State of the City, Speaker Adams introduced peer-to-peer wellness groups for students, which will include support from CUNY social work students. Has DOHMH held conversations with DOE and CUNY on these programs, and what is DOHMH's timeline to implement wellness groups within the schools?
Thank you for the question. We're eager to learn more about that model that the speaker mentioned. We are very committed to peer-based services. We implement peer-based services throughout our mental health programs. I ran an organization that was built on peer-based services, so we know how important our peer workforce is. We're grateful that we're in a state, one of the few states that actually has recognized state licensed peer clinicians. And so we're committed to doing this and eager to learn more about what the speaker has in mind.
Okay. In the state of the state, Governor Hochul announced the funding of a school-based mental health clinic in any school that desires one. Have you held any conversations with the state on when the city will receive these school-based mental health clinics? And when do you believe the funding for these programs will be reflected in the city's budget?
Thank you for the question. I can defer on the budget questions, but we are seeing it in the numbers.
Yeah.
5 new clinics opened in last calendar year alone, and 25 are pending. So the money is flowing. We're in close partnership with the state. We're very excited about this expansion.
Nice. Okay, and then moving on to maternal mental health, just a few questions. Maternal mortality and morbidity are pressing concerns in the city, but one aspect of this issue that often is not discussed as much is maternal mental health. The fiscal 2025 budget added $1.9 million for maternal mental health services, including doula services, which is great to see that. And what is DOHMH's total budget for maternal mental health, and what specific maternal mental health programs is DOHMH going to offer?
Thanks for the question. Our maternal mental health work is spread across multiple divisions, so we don't organize it in one division, and so we're happy to get back to you with some estimates there. But it's a massive issue. Suicide and overdose remain the leading causes of death for pregnant and postpartum women in New York City. Of course, that affects women of color at higher rates, who also experience higher rates of postpartum depression and lower rates of access to care after pregnancy. So our perinatal mental health initiative supports training and capacity for health department teams who serve pregnant and birthing women, such as doulas, nurses, home workers, home visitors, and social workers. We have a very robust home visiting program through our nurse-family partnership, our newborn home visiting program, our new family home visiting program, all of which are intended to really serve women in that critical period, that first year after delivering. And so that's a lot of our focus. Happy to get you more details, but it remains a big issue.
Okay, yes, and if you could get specific numbers, if you have them now, great. If not, about the budget for the doulas and also how many doulas currently are working for DOHMH.
I'll kick it to my CFO, Aaron Anderson, for any details he can provide.
Good morning. Just give me 1 second. So the current budget for doulas is $4.5 million.
And how many, do you know how many that equates to in terms of numbers of people?
I think we'll have to get back to you on the specific number of folks.
Okay, yes, please. Okay, great. And next, I just wanted to quickly go to workforce retention, which we know is a big problem across all of our agencies and sectors. So right now, there are currently, if I'm not mistaken, correct me if I'm wrong, 183 vacancies for mental health employees at DOHMH. What is your current retention rate with the mental health focused employees? And what are some of the reasons or challenges that you're facing in terms of the retention issues?
We have an overall vacancy rate. We don't really calculate it out separately for mental health. We have an overall vacancy rate of 10%. That's down from past years. We were 12% last year. And encouragingly, for the first time in 4 years, we have more onboards than separations from the agency. That's a big change. We saw massive turnover over the last 4 years with the public health emergency, with federal grants expiring, with, frankly, trauma, low morale, and issues around equity and pay and telework. The telework has been a big step forward. Grateful to our partners in labor and our Office of Labor Relations and others, DCAS, for negotiating a telework option because that's been massive in terms of retention. We are now in step and in line with the rest of the labor market, and so that's been a big deal. We do everything we can to retain workers, particularly in mental health. I think the focus of my focus and the agency's focus on mental health has actually been really good in terms of attracting new talent into our mental health work. There's always more work to do. I'm very proud of the investments that we made into worksite wellness. One of the first things I did when I arrived more than 2 years ago was expand the budget of worksite wellness offerings, knowing that, of course, each initiative is just one offering, but we had to expand the kinds of offerings, whether it's meditation programs, wellness programs, connections into mental health care, as well as we worked very closely with our OLR to really look at our mental health benefits within the plans that we were negotiating as a city. So we're trying to prioritize mental health care for our workforce, but also prioritize the offerings we make in-house for our staff.
Thank you. And if you could actually give us a breakdown later of that 10% overall, that would be great in terms of the mental health versus other staff. So thank you for that. And then also, did you provide COLAs to the mental health employees? Is that also part of the budget?
I can kick it to Aaron for more specifics, but the COLAs, I believe, were focused on the human service sector, which are, contracted vendors for a lot of DOHMH programs, and that's a great thing. We are very supportive of what the mayor and the speaker and the budget director did to expand that. I'll kick it to Aaron for any more details.
Yeah, nothing more to add, but we're absolutely thrilled about the new announcement about
Okay.
COLAs for.
Great. And going to I had a couple questions around Be Heard. I don't know if we're at quorum right now, but I know that some of our other, council members later also have questions about this. So I'm just going to go ahead and ask questions, a few, on Be Heard. And I know that this is an interesting program because it does involve so many different agencies. It is a collaborative effort by DOHMH, FDNY, NYPD, H&H, and OCMH. To address mental health emergencies. Be Heard responds to emergency 911 calls with 2 ENTs and 1 mental health professional from H&H. So what is DOHMH's direct role with Be Heard?
We are very supportive of Be Heard. I'm very supportive both professionally, personally, and otherwise. As an institution, we are very supportive of health first responses to mental health crises. As of today, we don't have a role in Be Heard, so I would direct your questions to OCMH, who oversees the program, and the agencies directly involved. We do not have a direct role.
Okay. Does Be Heard have Medicaid reimbursement that you know of?
I'll just direct you to OCMH and others to answer.
Okay, so can you answer any questions about the Be Heard program?
We do not have a direct role in Be Heard in any way.
Okay. Interesting. Okay, I'm going to come back to this actually. Okay, and I just want to note for the record that this is a hearing we've been requesting for a while for Be Heard, so hopefully it is something that we'll be able to get on the calendar very soon. Just want to make a note of that. Okay, so next I wanted to actually go into questions about clubhouses. And I'm going to go a little off script here because this actually worked out timing-wise, where I had a site visit planned at one of the smaller clubhouses that was on the books for yesterday, and it was the one that Lifelinks, which is actually located in Elmhurst Hospital, actually, which is great because they have an inpatient unit, inpatient psych unit. They have all supportive services within the hospital setting. So I had the opportunity to go there yesterday with Councilmember Krishnan, since it's in his district, in Elmhurst. And this public hospital serves over 1 million residents across Queens. And as we all know, Elmhurst Hospital was the epicenter of the epicenter when it came to COVID. And the reason why I'm going off script a little bit is because I have to admit, I got in tears and very emotional yesterday listening to some of the stories of people who go to these clubhouses and their family members. And some of the stories that we heard that were very hard-hitting was a father who was there speaking on behalf of his son who died 2 months earlier, that loved the clubhouse and said his son would have lost his life sooner if it were not for the clubhouse. There was a man who was suicidal that was there, showing us his scars and how important this clubhouse meant to him in terms of his daily struggle with mental illnesses and his recovery. A number of individuals there were there with several social anxiety disorders. There was a son there, actually, which was amazing for me to see personally, of Asian descent, where his parents were with him to support him. So they actually come with him and take time off from work to support their son at this clubhouse. And they were crying because they were so grateful. And some of the things that they urged us was that, nationally, I think the average daily attendance of clubhouses across the nation is about 100 people. And they felt very strongly that the smaller clubhouse setting for them, especially those dealing with social anxiety disorders, was so important. And the new RFP that came out, the minimum number that is required is 300, right? And so they're worried that their clubhouses will not be able to exist because of this minimum requirement. And so I think my series of questions that I wanted to ask, if you could just simply respond with yes or no, that'd be great. And I just wanted to ask a series of questions. So after hearing some of the stories and hearing some of the essence of their stories that tell you how much these programs matter and how they feel seen, do you believe that small clubhouses have a role to play in our mental health system, yes or no?
I'm sorry, but I'm not going to answer your questions as yes or no. because
If you could answer just yes or no, that'd be great.
These are not yes or no.
These are very simple questions that are yes or no. If you believe that smaller clubhouses have a role to play in our mental
I
health
believe
system.
that everyone with serious mental illness who is in need of the
Okay.
powerful rehabilitative effects of a community deserves access to a community.
Okay, so I'm assuming that's a yes. Do you believe that individuals with social anxiety disorder will feel comfortable in clubhouses that are much larger, yes or no?
I'm not going to comment on that. I don't have a comment.
Okay, because that's what some of the folks were telling us yesterday. So from a narrative perspective, that's what these people are telling us. And is it your belief that these individuals will matter and will feel seen in clubhouses that are far bigger than where they are now?
Our goal is to make sure everyone feels
Yes or no?
they matter.
Yes or no?
and
Okay.
they're seen.
Do you believe removing a clubhouse from a public hospital like Elmhurst, the epicenter of the COVID pandemic nationally, will improve the mental health and well-being of those who visit the hospital and this program, yes or no?
I think that expanding access to the clubhouse model remains my goal, our goal. This model hasn't been expanded in 35 years.
Okay, so then to that point, let me ask, if we're talking about expansion, why can we not expand on top of what is already existing, as well as slowly trying to push people towards different models? Because I think there's something to be lost, because we're not talking about, as you said, we're talking about individual people. We're talking about someone who is a human, as a whole person. They are not a number, they are not dollar signs, and this is something that we need to make sure that we're addressing. So I understand that in the budget, for maybe there's efficiency purposes or something that is there, but I refuse to support a notion that some of the smaller groups are not effective and impactful in the community. Because as someone who came from the nonprofit sector for 20 years, that ran social service agencies as well, I will say that some of the groups that we worked with are smaller nonprofits that have linguistic, cultural, specific skills. And they are having a huge impact on the community because of their reach into specific niche populations. And so my last final question, which hopefully will be an easy yes or no, is will you join me in a visit to the Elmhurst Hospital LifeLinks Clubhouse and hear directly from the patients and the clients themselves?
Happy to talk about that with you.
Okay, thank you. No, it's okay. Okay, so going to the questions now around more details about how the RFP was drafted. Were you able to consult the council's mental health roadmap to ensure that the changes in services recommended within this RFP were in line with the roadmap's priorities? Because what we had said during our roadmap is we want to add 5 more clubhouses, but that was under the former RFP, which had the minimums of clubhouse attendance much lower. So I guess my question is, did you consult with the council's mental health roadmap to ensure that these changes were taken into consideration?
As you know, we launched a mental health plan last year, which committed to expanding access to clubhouses for the first time in 30 plus years. And so that's our focus. We, of course, are aware of the council's priority on this. Ultimately, the proof is in the pudding, which is, are New Yorkers with serious mental illness actually getting access to this model? One of the things that I've struggled with in working in this space directly and watching people's, for every story you've just told, I've heard 10 more in this very same model of care, visiting every single clubhouse around the city. And the hardest thing for me to accept is that we unintentionally constrain access to this life-saving model. As a loved one of family members who died from serious mental illness, who growing up with people in my culture and in my family with serious mental illness, they never had access to a clubhouse, and they would have been saved. And so my sole goal is to ensure that this model is available to everyone and anyone who needs it and wants it. And in order to do that, we need to start organizing ourselves a little bit more smartly, better, and collecting data on impact. It really matters. I know it's about people, but we have to hold ourselves accountable. That's good governance. It's not just about the single person's story. It's about many people's stories.
I
and
agree.
The fact that for every story you're telling, there are tens of thousands of people who don't have access to a clubhouse because of decisions you've made, we've made, this city has made to constrain access to this model.
So then my
We've got to
question-
get sharper and smarter about this.
So then my question, though, to your point that you're bringing up is, when you're talking about access, why is it that the total number now is less or decreasing versus the previous one? And also, when we're talking about access, you know, I would think that we would want to expand these programs in different community groups, in different neighborhoods across New York City, because right now the neighborhoods around the city are decreasing. And so I'm just wondering if, you know, if there are communities in the city, you know, that how it's not, how the numbers, if they're decreasing, how is that increasing access? And also my second question is around the RFP, right? Because if you're talking about, yes, I agree, metrics, dollar amounts, they're all important, right? But my question is, were those metrics applied to and asked of community groups previously that were contracted with? So in other words, if you're only asking for the daily average attendance, that's what they're going to give you, right? But if you challenge them and ask them for other metrics, I guarantee you all these nonprofit groups and community groups and clubhouses will be able to provide that. So I want to know how deeply, and this goes to my next question, is how deeply were the nonprofits and the community groups consulted in this RFP process?
I can't really comment on the RFP, right? It's an open RFP.
But it is an RFP that you drafted, correct?
I certainly did not personally draft this RFP.
Your department
but
drafted,
our department
yes.
drafted it. And yes, we've been working with clubhouses, funding clubhouses for 40 plus years or more. And so we're intimately familiar with this model. We convened the Clubhouse Coalition, which is a coalition of all the providers. We've heard these challenges and complaints for years. And
Can you go more specifically into the challenges and complaints that you're talking about?
we have convened the Clubhouse Coalition of every single contracted clubhouse provider for more than 20 years. And we consult with them on a regular basis. And so from that, we glean a lot of data, a lot of information around their challenges. One of the core issues here is, how do you compare the rehabilitative quality, which is really an important point, of a program that has 3 staff and 25 people attending with a program that has more staff and the ability to offer more rehabilitative services. This isn't about just bringing people to a site and then letting them hang out. This is about active rehabilitative services. And it's about active engagement. I know this model very well, council member. And so, you cannot tell me, and the data doesn't bear it out either in New York City or elsewhere, that the outcomes are comparable between programs. You have to offer the right levels of rehabilitative service and quality in order to get the outcomes we want. I'm going to kick it over to our Executive Deputy Commissioner.
Okay, but before we move on, so just to your point, you're saying if there's a staff of 3 and of 25, in the previous RFPs, were there not sort of requirements of what services they need to offer? And also, I will say that, to your point, each program, each individual is different, right? So maybe I don't need the extreme set of rehabilitative services that a group of 500 members in a clubhouse would have, right? And so my question is, to your point earlier, why does it have to be or? It could be and, right? So is there a place, and this is going back to one of my original questions, is that I do believe there is a place for smaller clubhouses in smaller settings that still provide quality services. And this is the notion that I'm trying to get at, is the underlying notion that I'm hearing is that the smaller clubhouses, if you're 25, 50, 100, in my opinion, it doesn't matter. If I'm getting help at this clubhouse and I feel heard and I feel seen, how are you to tell me that that is not having an impact on my mental health recovery?
I'm going to kick it to Deepa for more.
Deepa Avula, Executive Deputy Commissioner for Mental Hygiene.
Sorry, Executive Deputy Commissioner, could you please raise your right hand? Sure. Do you swear to tell the truth, the whole truth, and to respond honestly to council member questions?
Yes.
You may proceed.
Thank you. Councilmember, thank you for your questions. I wanted to address a couple of things about the RFP and the process, because obviously our commissioner's not involved in the details of developing that and working with stakeholders. So one of the things that we are required to do when we put out an RFP is we're first required to put out a concept paper. That concept paper was actually much more ambitious than what we had, sort of what we ultimately landed in the RFP, based on feedback from providers. So there's a public comment period. Though providers can comment, members of the public can comment, anybody can comment during that period. Those comments were very carefully reviewed, and edits and sort of course corrections were made in our RFP development. Once the RFP itself was posted, we then do conference calls and webinars with potential applicants, with, again, members of the public. Anybody can join these calls based on feedback from those calls. The RFP was further edited. A couple of the edits that were made were things like people thought our calculation on average daily attendance was too rigorous. We pulled it back. We wanted originally 40% of active membership. It's now 30%. We wanted people to reach their active membership target in a shorter period of time. We said originally 6 to 10 months. We extended that time period for a ramp-up period of 2 years based on the feedback that we got from providers. People said, you haven't given us long enough time to apply for this. We need to extend the deadline. We extended the deadline. So I wanted to make sure that feedback that was received by providers, by potential applicants throughout the process was incorporated to the greatest extent that we could, while still being held to the rigor that we ultimately wanted for this population and this model.
Okay, so I just want to clarify that the amendments mostly that were made were to increase the tiers of the number of the clubhouses. And so, again, my question is, because what we've heard from the community groups on the ground is something very different than what you're describing. And what they urged us to urge you on is the fact that they needed the numbers to be lower than 300, because, as I mentioned earlier, the national average of clubhouse attendance is about 100. So my question is, and I would love to see which groups commented, who gave feedback on what, because what I'm hearing is very different. And I'm just telling you from a person who has been on the ground talking to a lot of these advocates, and I get that you come, and I understand that we're all sort of agreeing to the same holistic goal that this program is important. We don't want to let it see it die. But as coming from a smaller nonprofit, I feel very passionately about this issue, not just about clubhouses, but the way that our city sees these smaller agencies that have a huge impact in the communities that they serve. And just because they're not meeting all these perfect metrics doesn't mean that the work they're doing is not valued.
Sure. No, and we understand that. And I don't think anybody is saying that services are not valuable. I think we as public stewards also have to make sure that the services are as high quality and evidence-based and rigorous as possible, and also really carry the fidelity to the clubhouse model and the standards. So as you note, if 100 is the average across national clubhouses, we have a membership, active membership is 300. That's our requirement. Average daily attendance is 30% of that number. So it's actually 90 people. So the standards that we've put out are very doable based on even the information you're sharing. So one of the things that we have really tried to do, because we care so deeply about individuals with serious mental illness and because we want them to get the best care possible, we had to put some standards to ensure that we were meeting the needs, right? There are 240,000 people with serious mental illness in our city. Only 5,000 of them currently access clubhouse services.
So that goes to my last question on this topic, and I'll move on to something else. But the law that we had, Local Law 119 of 2023, which was something that came out from the council's roadmap, it required the mayor's office to establish an additional 5 clubhouses in the city on top of the ones that were currently there. So do you think that you can do that and that you will reach that goal? And my question is, to your point, I know some clubhouses that actually did not apply because they didn't meet that minimum number. And so the question is the messaging obviously didn't get reached to all the groups that were current and previous clubhouse providers. And so my question is, what is also then going to be the next steps to make sure that they're still included into the mix?
So again, right now, we're in the middle of the sort of active review process. Once we know where the final applicant pool or final awardee pool will land, we will then reach out to all of the applicants, whether or not they received an award, they will hear from us, and we will work with individual applicants who either did not receive an award or did not apply for one to ensure that there's proper either transition of their membership or that there's linkages that we can help support. But we don't have specific answers to that right now because we just don't know where the ultimate pool will land.
Okay. I just had a few questions, follow-up questions on Be Heard. So I know that it's mostly sitting with OCMH, although it's interesting because when we've asked them about it, they tend to defer it to other city agencies. So does DOHMH plan to liaise with OCMH in the near future to oversee the coordination of Be Heard?
We don't have that sort of inroads into that program. We don't control Be Heard's budget. We don't see anything about Be Heard operations because we don't have an active role in the program.
But the website, the DOHMH website says that you guys are involved with Be Heard. So I think this is where a lot of the confusion is right now, because the website says that you guys are involved, and according to everything that we're seeing, there is a role for DOHMH. So I'm just curious to know how deep or wide is that role?
So just to clarify, so we have no involvement at all in the administration or management of Be Heard. Our teams cross-refer. So we refer to one another. So Be Heard may refer to our co-response team. We may refer to them. We have involvement in other crisis teams. But as for the management and administration of the Be Heard program, DOHMH has no involvement in that.
Okay. Do you believe that peer-led workforce could aid in mental health non-police crisis responses?
Yes.
Okay. Okay. Thank you for saying that for the record. And the last question I'll ask before I hand it off to my colleagues is just one question around supportive housing programs. And I wanted to talk about supportive housing, but I'll focus specifically on the New York City 1515 program. So this program was launched in 2015 with the goal of constructing 15,000 units of supportive housing over 15 years. Halfway through that time frame, though, which we're in, we're not keeping pace with the goal. So I understand that DOHMH, HRA, and HPD are currently in conversations with OMB about the future of the program and how to restructure it. So do you have any information or updates to provide on the restructuring of the New York City 1515?
Thanks for the question. We can't comment specifically on any restructuring, but I can tell you our role and what we have done recently. We focus our work on the services. We run the service contracts associated with supportive housing sites. So we focus entirely on what are the supportive services, clinical services and otherwise, that people who are in supportive housing get. So we're not really involved in the units or the construction or that piece of it. That, as you said, is our partners at HRA and DSS. There are currently a total of about 12,000 supportive housing units in New York. 76% of those are congregate and 24% are scattered site. In FY23, we opened 724 new units for people experiencing homelessness, mental illness, and substance use disorder.
Okay. And I lied, one more question, sorry, about opioid settlement funding. The state has, and I'm curious to know what you all know because we're not seeing a lot around this, or we're not given a lot of information, but I know the state has reached multiple settlement agreements from the opioid manufacturers and distributors, and according to the state fiscal 2025 executive budget, the state expects to receive more than $2 billion through 2040, $2 billion. I just want to say that again. DOHMH has 14.6 million, OCME has 800,000, and H&H has 14.6 million in opioid settlement funds. So what does, if you could explain a little bit more about how you've spent the settlement funds up to date, and is there collaboration with OCME and H&H on the opioid settlement funding?
Yeah, thank you. There is collaboration on the funding. We have set out a target of reducing fatal overdoses by 2030 by 25%. In order to get there, as I said, passionately in a previous response, we're going to need every tool in our toolkit to get there. We can't take anything off the table. We have been allocated one tranche of the opioid settlement funds, and the numbers you stated, I believe, are accurate. That tranche awarded in June 2022 was used to both extend and expand wraparound services and hours of operation at our 2 existing overdose prevention centers. We heard very clearly, because we know they're saving lives and interrupting overdoses, we heard very clearly that people wanted those to be open for expanded hours, weekend hours, after hours, and to offer a wider suite of services. We recently announced that an additional $3 million per year would go to Staten Island providers, and we're in current discussions with OMB around any subsequent, the use of any subsequent tranches of funding.
Okay, thank you. And is there any talk of anticipating receiving more funds in the near future?
I believe we anticipate receiving more funds, and we are in discussions with OMB about how those will be used, but we are working in a unified way towards that goal of 25% reduction by 2030.
Okay, great.
Commissioner, I just want to ask a couple of more questions, and then we're going to give it over to our colleagues. One is, people that have contracted COVID-19 are susceptible to developing long COVID, in which they have the same symptoms that they had when they first tested positive for weeks or even months after they tested negative. How many cases are there of long COVID? I'm going to ask these in a row so that we can go through these. And what parts of the city is long COVID most prevalent? And the city received funding for COVID-19 prevention and treatment services. Was any of this funding allocated to treating long COVID?
Thanks for the question. I think we're actually really early in our understanding of what long COVID is. We know it's real, but because COVID is such a new virus, the actual case definition of what is long COVID is changing rapidly. We are very grateful to our partners at H&H for standing up some long COVID centers of excellence where people can get their concerns heard and to get care in specialized centers that focus entirely on long COVID. But one of the things we need to do, and our job at the health department, is to really advance understanding about this illness. And so we're very proud to have announced a new long-term observational research study, a long COVID cohort study, built similarly to how we do the World Trade Center registry. We're going to be building a long COVID cohort study to really study what are the long-term impacts of long COVID on health, and to come to some clearer understanding of what is long COVID, what is that case definition, and what's included, what's excluded, and how it's impacting New Yorkers. So once we have that study up and running, which is federally funded, not city funded, we will be able to provide clear answers on who has and who doesn't have long COVID.
Okay, I want to ask a couple of questions on the animal care centers, which we haven't asked about. DOHMH's preliminary fiscal 2024 to 2028 capital commitment plan includes $521.8 million for various capital projects. What are the major capital needs for public health?
We're very excited for the new animal shelters that we're constructing, particularly the one in Queens, which we're very grateful to, that is going to be renamed after your late colleague, our late colleague, Paul Vallone. I'll kick it to my colleague, our CFO, for any details on the capital expense.
Yeah, thanks for the question. There's about $164 million budgeted for various animal care center projects going on. We're delighted to say that the Queens shelter is opening this year and the Bronx shelter is under construction, and we expect substantial completion to occur next year.
Okay, what is the current operating budget for ACCs broken down by location? If you don't have that, you can send it to us.
Yeah, the total is $34 million in FY25. We'll get you the details.
Please. And what are there any new capital projects for ACCs, or just basically what you spoke about?
Yeah, the continuation of all the existing ones.
Okay, and my last question is about Legionnaire's disease. So I know that there have been several cases in and around the city recently. As you know, Legionnaires is a severe form of pneumonia caused by Legionella bacteria, which is found in freshwater environments. How many cases of Legionnaires have there been in the past year?
Every year, we have about 200 to 300 cases of Legionella. It's a seasonal illness in general. 300 to 500 cases per year. Apologies. It's a seasonal illness in some ways because it's associated with water tanks, water cooling systems, which are in greater use, of course, during hotter weather. It's a very low risk for the general public, but people who are more susceptible are people over age 55 and those who have underlying chronic health conditions. We have a very robust surveillance system. We work very closely with landlords, building owners, and operators to do that surveillance and to monitor for cases and also to track for and to do building level investigations.
Can you tell us how many building evaluations has DOHMH conducted due to confirmed cases of Legionella?
We're happy to get back to you with
Okay, and how often do building owners need to test for it?
happy to get back to you with
Okay, and
details. There's a routine protocol.
We'll
for
send you,
testing,
what is the
depending on-
percentage of building owners that are
Yeah.
up to date with their inspections, but how does DOHMH ensure compliance? That you can answer, right? Or
Well,
you
we,
need to get
we
back?
do it through routine inspections,
Okay.
reporting. I'm happy to kick it to my Deputy Commissioner of Environmental Health, Corinne Schiff, for more
Okay.
details.
Thank you. She has to be sworn in.
Please raise your right hand. Do you swear to tell the truth, the whole truth, and to respond honestly to council member questions?
Yes.
Thank you. You may proceed.
Corinne Schiff, I'm the Deputy Commissioner for Environmental Health at the Health Department. So your question was about our investigations when we determined that there are 2 cases of Legionnaire's disease within 12 months at a shared address where there's a shared hot water system. That's what triggers a building level investigation. And when we do that, we direct the property owner to do water sampling and remediation if Legionella bacteria are found. We provide technical assistance to that property owner to stay on track with that order, and then they come out from under that order only when their remediation is shown to have succeeded in addressing the Legionella bacteria.
Okay, and how do you ensure compliance by the landlords, building owners?
There's a water sampling protocol,
Okay.
and they follow that. And when the results of their sampling show that the Legionella bacteria have been addressed, then that is demonstrating compliance, and they've satisfied the order.
Thank you, and I want to thank my colleagues for indulging us chairs on this line of questioning. We've been joined by Councilmember Gennaro virtually. First is Councilmember Ariola.
Thank you so much, Commissioner. I just would like to know how much DOHMH is spending on advertising for people from other states to come to our city for abortions.
Thank you for the question. I'll send it to my CFO for specifics, but I don't believe we're currently doing that right now.
You aren't, because I think that money might be better spent on building the library that Chair Schulman was talking about.
I'll kick it to my CFO.
Okay.
Yeah, I think we'll have to get back to you on the specifics.
Okay, great. And I just want to go back to what Chair Schulman was talking about with the anti-OD life alert device. I read the article, said that that'll be paid for by taxpayer dollars. And we also talk about overdose interruption centers, but nowhere in your testimony do we talk about any drug treatment and outreach programs, which is really another way to save lives, and that is the main focus of this health committee. What is DOHMH's plan to expand drug treatment programs and outreach for those programs?
I just want to correct the record. My testimony is very clear that we are supporting buprenorphine access in the community, buprenorphine being medication-assisted treatment for opioid use disorder. We're doing that in primary care settings. We're doing expansion of naloxone, and we are connecting people who have experienced a non-fatal overdose, which is the highest risk group. If you've experienced a non-fatal overdose, your risk of having a fatal one, connecting them into treatment as well as other supports. So idea that we are only doing one thing is just not accurate.
So what I think we're doing is more enabling. And naloxone, I think it's great, we have to do it. I think we have to do all these things, but they're enabling people to do drugs. I came from a hospital setting, as you well know, and there are very few drug treatment programs in our hospitals. What are we doing to expand those programs in hospitals, both city, not-for-profit, and for-profit, as well as doing outreach where people know they can go to a hospital for treatment and then for short-term treatment and then long-term treatment for their drug addiction disease?
We agree that treatment is a crucial strategy. Treatment is also extremely difficult. The failure rates of treatment are very high for opioid use disorder, particularly in the era of fentanyl. We're very glad that our partners at H&H are actually using their portion of the settlement dollars to expand access to treatment, while we are expanding access to community-based treatment, including working with primary care centers to expand access to medication-assisted treatment like buprenorphine. As you know, methadone and other forms of hospital-based or clinical-based treatment is overseen by the state.
Yes, but I would love to see people go into treatment and become drug-free. Thank you so much for your testimony.
Thank you.
Councilmember Mealy? No. Councilmember Zhuang?
Thank you, Chair. I actually want to thank two chair ask really good questions. The question I want to ask, you guys already asked, but I have a couple additional questions. What resources you guys give for new immigrants group for the drug addiction? Because in my district, I see a lot of new immigrants, especially the one that doesn't speak English, has drug addiction problem, but never know where to get help.
It's a great question, Council Member. As you know, the city has faced an incredible influx of asylum seekers in the last 2 years, as well as new immigrants that always come to our city. And those new New Yorkers have faced incredible journeys to get here and are often subject to trauma and mental health concerns due to histories of violence and other forms of oppression. So they are at risk, especially with fentanyl involved in over 80% of our fatal overdoses. So this remains an area of work that we are interested in building out. Currently, we focus a lot of our mental health outreach in linguistic and cultural minorities in the areas that I mentioned, in particular our work with faith-based organizations, as well as the API community work that I mentioned.
And how much you willing to invest in this area in your budget? How much percentage?
We can get back to you with further details. Thank you.
And also, I really like Chair Linda Lee asked about Clubhouse. I did a little research. In our community, we don't have any. Actually, the people in our community really need some. Is anything you guys already did in Southern Brooklyn I did not know about the Clubhouse, the mental resources they can use? And especially in different language, how much resources you guys put in different language?
Yeah, it's a great question. One of the areas in the RFP for clubhouses is not just expanding the number of sites or expanding the number of people served. It is really about making sure that those sites are also in the highest need communities, which is also, I believe, the spirit of or specifically stated in the council's bill on clubhouse expansion. So we have zip code-based criteria, or at least considerations where those zip codes are aligned with the greatest areas of greatest need in mental health crisis, lack of access to care. And so language and cultural competency remains a huge piece of this. Ultimately, the clubhouse model and clubhouses across this country have been relatively constrained in their funding, and so we're trying to grow that base of funding.
You answered how you agree with me, but you did not answer how you're going to expand and how much expand.
We doubled the funding for clubhouses in this RFP. So that's the first major expansion of funding for clubhouses in decades.
And how much did you invest in minority group?
We can get back to you with specifics.
Okay, I'm looking forward for the data.
Okay, Councilmember Hanif?
Thank you, chairs, and Commissioner Vassan. Great to see you.
Good to see you.
Commissioner Vassan, can you walk us through the public health strategies in place for disease prevention and mental health services for immigrant communities, and particularly for Asian, South Asian older adults? And I'd love to know if there's disaggregated health data available on Asian ethnicities and how you're adjusting your work, and if there's data on the NYC Care enrollment and outcomes.
Okay, let me try to flag all your questions. I can answer the easiest one first. NYC Care is a program run out of the health and hospital system, so not...
I guess walk me through the disease prevention part, because in my community, I think the outreach isn't reaching folks who now have illnesses that could have been prevented. And that's a big issue. What is the city doing to ensure that our communities that are working very hard, long hours, now have high blood pressure, high cholesterol, diabetes that could have been prevented, are now suffering?
Yeah, one of the programs we're most excited about in that vein is Public Health Corps, and this is a perfect example of a program that was built during COVID with emergency dollars that we're working hard to figure out a long-term funding solution for, but it is based on community health workers using in group ways and door-to-door and working through community-based organizations to engage people with chronic diseases in high-need neighborhoods, mostly focusing on our tree neighborhoods that have been historically disadvantaged due to legacies of racism and
So at this time, does the city have any protocol or programming geared toward outreach?
That's sort of what I'm describing. The community health workers, boots on the ground.
That exists.
That exists today, and we're exploring ways to transition it from emergency funding, federal emergency dollars, to sustain.
And what's the funding allocated for that?
We'll get back to you on details. We're still in discussions with OMB and otherwise.
And this is an existing program that will continue on and you're expanding?
We can't make any commitments right now. We're in discussions with OMB, but it is a priority. It was funded with federal emergency dollars, and that represents a big challenge as that money expires. How do you build permanent programs with temporary emergency dollars? It's a
I'll
challenge.
be following up. Yeah, the public health of all New Yorkers is critical, and particularly at this moment when we've welcomed so many asylum seekers and coming out of COVID. And I appreciated Chair Schulman's question about the study for long COVID. The health of New Yorkers should be our utmost priority. My second question is there specific funding allocated to DOHMH for subway safety? Based on the 2022 subway safety plan, there was a line item about neighborhood response unit teams, 12 neighborhood response unit teams, which would include medical staff, clinicians, peers, which would provide services. And I think this is a really great opportunity for mental health services within our subway system. And this was included in the subway safety plan. Is that still the case? Are we at 12 units? Have we implemented this plan? Or have we increased the number of units? How much funding has gone into this? We're spending $155 million for police overtime. How much have we spent on the neighborhood response teams?
Yeah, thanks for the question. We are very committed to partnering with our partners in the Department of Homeless Services and law enforcement with the co-response model that the subway safety plan
Commissioner Vassan, how much have we spent on
we'll have to get back to you on details.
Does this exist? The neighborhood response teams?
Yeah, so this was a program that was launched, designed and launched towards the end of the last administration. We have a range of outreach teams, most of them designed to do very specific functions, and when the subway safety plan was launched, we redirected a lot of their work towards the work underground and then, of course, above ground as well.
Got it. Thank you.
Councilmember Bottcher.
Good afternoon. It's no secret that we are failing as a society in addressing the mental health crisis, and you don't have to go far in New York City to see how badly we've been failing with people dying of untreated mental illness on the streets and in the subways, in the richest country, in the richest city in the world. New Yorkers see this more than anywhere on the subway system. And I would love to give you an opportunity briefly to tell New Yorkers what steps are being taken to address mental illness on the subways. We hear a lot about police officers. We have troops in camo. Most New Yorkers do not see mental health outreach teams engaging with the person who's in the subway car with them who has severe mental illness. If you could talk about briefly what the plan is now, what's happening now, and what the top barriers are to getting a handle on this problem.
It's a very challenging problem. I'm grateful to the administration for prioritizing it from early January of 2022. We made this a priority, but it is a challenging one. The subway work that we launched then was largely focused on being stationary at certain key locations throughout our subway system, and that's with Department of Homeless Service outreach workers, social workers, as well as our clinicians and other staff. Recently, you may have heard the governor announce the expansion of a pilot we started called the Scout program, which is more about, I think, what you're describing, which is mobile teams that are actually riding the subway as it's moving, going station to station, and staffed with clinicians, homeless outreach workers, social workers, and really trying to start with this engagement-first approach. Sometimes, and you know very well, council member, having been engaged in this work for a long time, it can take multiple engagements to build just that modicum of trust to get someone to accept services or to come in from the subway system to shelter or to respite or to the hospital or anywhere else. And so I'm always impressed every time I go out with my colleagues at DHS as well as our clinicians. I'm incredibly impressed with the care and the attention they give to people as human beings and really working in that engagement first approach.
How many Scout teams are in the system at any one time?
Well, right now it's a pilot, but the governor just announced that the state was going to be putting in more funding. That's also a partnership with MTA, just to be clear. We can get you details on what she announced. I don't have that on the top of my...
Why do we need a pilot for a program like the Scout team? We know that this is how you address it. Why isn't the city and state flooding the subway with mental health professionals and outreach teams?
Well, I think we have some big challenges. Number one, I don't know that we know exactly what will make a difference because otherwise we would have solved it already. This is a growing problem. It's a long-standing problem as well, and this administration has put its attention on it in a way that I don't believe others have. And so we are actively trying to problem solve as we go and learn as we go and collect data as we go and to improve. Number one. Number two, I think that, we have to get down to the root of the fact that we have a massive workforce crisis as well. The idea that there are droves of mental health workers sitting on a shelf, not working in the subway, ready to go into the subway is just not accurate. It's not representative of what the state of the mental health workforce is, which is why it's so important what the city council did, what the mayor did last week to increase the COLA for human service agencies. So much of this work is run by human service agencies that are in contract with the city. And having run one, I know how much we struggled with recruitment and retention, particularly of social workers and clinicians. And so this goes a long way to improving that. This is long work. I often think about it as in medicine, we have something called refeeding syndrome. If someone is chronically malnourished, you don't just pour food into them immediately. You feed them slowly and bring them back to life. You can actually make them sicker by giving them too much food too soon. Our mental health system has been chronically undernourished in this country. The city's no exception. But we are bringing it back to life with the investments that the governor has made, the city has made. Year on year, we're going to see floor on floor of this system that we've always needed, always deserved, but never had.
Thank you for identifying for New Yorkers one of the big challenges we're facing, which is a shortage of mental health workers and social workers. I have a bill that would put social workers in police precincts to intervene in a positive and meaningful way when people are brought into a police precinct. But we don't even have enough mental health professionals to service the bills that we've already passed, the programs that we've already funded. So that's a big problem that we have to address, but we have to address it, and we have to address it very quickly, because New Yorkers are, they've really lost patience, and I don't blame them, and people are dying, people are hurting. You have our partnership here to help address this, but I really would like to talk about what we can do to upscale the teams on the subway and do it much quicker than we have been.
Councilmember Marmorato?
Thank you, Chair. Hi.
Hi.
Good afternoon.
Hello.
So I would like to discuss the Zadroga program. My family included, many of my constituents have worked down at Ground Zero, and it's not an assumption that people are getting sick and dying and being diagnosed with cancer. We're seeing it when we go to the supermarket. My father sees his coworkers, and they're discussing their health issues and what's happening. I wanted to know, did you document how many individuals have become ill in the past few years from long-term effects of working down at Ground Zero? Do you have a number associated with that?
Not on my head, but Councilmember, we are so proud of our World Trade Center Health Registry. People think that research is just research. It's not. It affects people's lives. We, as a result of us building that registry, we have unlocked disability payments for your family, for families who are at and near Ground Zero. We have changed federal laws. The data that we produce has led to massive advocacy for Ground Zero families and victims and loved ones. And so, yes, we collect that data all the time, and happy to get back to you with
Is there a way that the public can access that information?
It's a great question. We're happy to get back to you.
Okay. So I do see that there is a change in budget. Let me see here. From 2017, there was a savings of 17 million, and then, 2024, there was a savings of 17 million. In 2025, it looks like 24 million. What is happening here? Why is there a change in budget, and is it to improve services? Is it because of, can you just elaborate why there is a change?
I'm going to ask my CFO to comment.
Yeah, thank you for the question. So this is basically a reforecasting based on actual costs that we've seen over the last few years. So it's really just a technical adjustment.
Is there just change in services? Are you changing what you're covering, or?
I don't believe there's been any change in that. It's really just to reflect what the actual costs have been.
Okay.
Yeah.
Okay, thank you. And just another thing I wanted to touch on is I see that there is an ask for about $300,000 due to congestion pricing. What are those funds going to be used for?
Thanks for the question. I'll bring in my Deputy Commissioner for Environmental Health to comment more specifically.
Okay. Hi.
Hi, Councilmember. Our work on congestion pricing is we are working very closely with the Department of Transportation and with MTA to do an evaluation of the air quality changes that happen once congestion pricing is implemented.
Okay. So this is just for research purposes?
That's right.
Councilmember Baccia had one follow-up question.
Commissioner, is the 988 number under your purview?
It is.
Could you talk about how you see the 988 number with respect to teams to respond to mental health crises? And I know that the Be Heard program isn't under your purview, but do you think that the 988 number could be used as a number for people to call to dispatch teams like the Be Heard teams?
You know, over time, we want those three numbers to be the go-to resource for all New Yorkers, for all Americans, and we're very proud to be working as a part of this larger national landscape of 988, so it becomes our 911. Right now, 911 is still the place where people go for help, but we want 988 to be that. The vast majority of people who call 988, and nationally as well as in New York, and that called NYC well in the past, are really not looking for crisis services. But over time, you know, I think that certainly is a hope and a goal. I'll kick it to Deepa for further.
Yes, so while the commissioner is correct that the vast majority, so 96% of people who call 988, their issue can actually be addressed on the phone, which is what we want. We want you to call 988 as early as possible so that you're actually not at the moment of a crisis. But when individuals are at the moment of a crisis, that's exactly what you described as what we do. 988 deploys a mobile crisis team to go to wherever that individual is. So whether it's their home, whether it's the street, wherever that individual is, generally it's from a residence. And based on the last year of data, which comprised about 420,000+ calls to 988, 13,000 of them received a mobile crisis treatment visit.
What progress is being made to getting to the place that you want to go when 988 can be used as a number for people to call with emergency response?
Just broadly, and I'll kick it to Deepa for more, we are seeing incredible progress, but lots of challenges. And they come down to some of the issues we already talked about, workforce. On the back end of 988 has to be expert clinicians, people who are trained to manage a range of mental health needs. And while we are very glad and proud of our partnership with organizations like Vibrant and otherwise that service that call line, there's work to do. There's work to do on that back end of workforce.
One of the things that we've done in New York City really to be an exemplar, to really realize the ultimate promise of 988, which is that anyone across the country can dial these three numbers. You don't have to remember a local number, and you'll get mental health crisis support immediately. So that's why we also sunset our local 10-digit number. And then the other thing that we've done with our mobile crisis teams, over the past couple of years, those teams actually took longer to respond. So it was more like a 24-hour response, so not a true crisis response. Our teams are now responding within 2 hours of time. So we've really seen very, very clear improvements locally, and we're hoping to expand on those improvements as well.
For a 988 dispatcher gets a call from someone, and in the judgment of the 988 dispatcher, it requires an emergency team response, a Be Heard type response. What is the sequence of events that happens in that case?
I'll kick it to Deepa.
So Be Heard is not routed via 988. So our mobile DOHMH run mobile crisis teams. Those are teams that are clinician health-led teams or clinician pair teams. Those are the teams that are routed. If there is an emergency need where a person needs to be there right away because we are worried that there is an imminent threat or an imminent harm, then we are routing to 911. We are currently working on an algorithm to also work with 911 to do the reverse, so that if they're getting a call where clinicians can handle it, we are going to be routing our clinicians as well. So we're in conversations right now with PD on how best to route those calls for both of us.
What's the timeline with that referral from 911 to 988?
That's currently in process. We're still working on exactly how that would work because the systems right now are different.
You're meeting about it, you're talking about it. Is that something that we could potentially see in 2024?
I don't know that in 2024. In 2024, there should be a good, solid plan for it, but obviously that takes time because of technology and other things as well.
And the technology is needed because it's more than just a phone call. It's a computer.
It's a dispatch, correct.
It's a dispatch.
Yeah.
And you're using external vendors to help you with the technology, or is the City Department of Technology involved?
So the vendor that operates our 988 system here in New York City as well as nationally is Vibrant Emotional Health, and I defer to PD on the system that they're using.
Councilmember Boccia, we appreciate your questions. If you want to talk to them separately, you can. Thank you very much. So I have one quick question, and then I'm going to close it out, and Chair Lee will close it out as well. So the question I have is, going back to Healthy NYC, the Office of the Chief Medical Examiner, everybody thinks of them as just doing autopsies, but don't they have a role in the data collection for Healthy NYC?
Yes, particularly.
Can you describe that?
Yeah, very much so. Our Healthy NYC program is based on a counting of life and death in New York City, and that is grounded in our vital registry. For over 200 years, we've been collecting vital records, and that has massive implications on funding, on census tracts, but also on disease control activities. And so all of the data in Healthy NYC is based on data that is collected on death certificates, which are certified by the New York City Office of the Chief Medical Examiner. So they are very close partners with us. In particular, I would say overdoses are a place where we partner very closely, because it can take time to really certify what was the cause of death when someone experiences a drug overdose.
Okay, thank you. So I want to thank you and your team for testifying today. I do want to say I'm somewhat disappointed that there weren't exact figures used in terms of budget figures, so we're going to follow up with you and your CFO on that. So we'd like to get that moving forward. But like I said, really appreciate it. Very happy to partner with you on Healthy NYC and other programs. And thank you for testifying today.
Thank you.
Yeah, and I just want to echo the same sentiments. Thank you for being here today, and I hope I sort of think of myself today as like a little Sour Patch Kid, because I know I was sour before, but now I'm going to end a little sweet, which is to say that, I want to be very clear. I do see us as partners, because we have to, the city and the people in this city, especially those suffering with mental health, are really looking to us to help them with their recovery, to help them fix their issues. And I actually appreciate these kind of conversations, because that's how we get to a better solution, is that we need to hear all sides. Whether we want to hear it or not, we have to hear it, and we need to make sure we take all that into consideration. So I really, really hope that we will continue the conversations and be partners. I know that I am very appreciative of the work you're doing around diabetes, especially because that's a huge issue that impacts our communities as well as us. And I will try to push the Article 6 on my end as well, because I do think that that's super, super important, and we need to get that funding from the state. So those are things that we will definitely try to push. But, my sort of earlier, is I don't get like that often, which is, people who know me know I don't get like that often, but when it has to do with issues that I really care about and feel very passionately about, I can't help but sort of dive a little deeper into some of these questions. So I really, really hope that you'll come with me to Elmhurst and visit LifeLinks, and I promise I won't bite, but I really want you to hear the stories of the people who are really impacted, especially from the smaller clubhouses that really feel the services every day, or just to visit any sites across the city impacting folks with mental health, whether it be the opioid treatment centers, the needle exchange programs. I'd be more than happy to go with you to some of these, because I think they're doing such incredible work. So I just wanted to thank you and your team for really being here and listening to all of our questions. So thank you.
Thank you.
So thank you. Just so everyone knows, we're going to take a 5-minute break, and then we're going to hear testimony from the Office of Chief Medical Examiner, and then go to public testimony. Thank you.
Can I have your attention, please? Can I have your attention, please? Quick announcement, if you are here for the Committee on Parks, once again, if you are here for the Committee on Parks, that hearing is going to be next door in the committee room. Please use the double doors and on your left-hand side. Thank you. Ladies and gentlemen, good afternoon. Please find your seats. Please ensure that all cell phones and electronic devices are set to silent or vibrate. Thank you for your kind cooperation. We shall be resuming momentarily.
Hi, I'm Councilmember Lynn Schulman, Chair of the Health Committee. We'll now turn our attention to the Office of the Chief Medical Examiner, OCME, who provides forensic research and investigates mortalities in the city. OCME's fiscal 2025 budget is $100.1 million to support 753 full-time positions. This budget was reduced by $3 million when compared to the fiscal 2024 budget adoption. The budget headcount has remained unchanged, and OCME is among the fewer agencies that were exempted from a program to eliminate the gap. Despite their smaller budget, OCME's work is immensely important to the city's well-being, and the autopsies they provide bring closure to the families of thousands of decedents. In addition, the data they provide is helpful to DOHMH in building strategies for disease prevention and will have a specific role in the rollout of Healthy NYC. At this hearing, I would like to make sure that OCME is adequately funded to provide effective services. In addition, we will discuss some of the results of OCME's preliminary Mayor's Management Report, specifically the rates of completion for their DNA cases and autopsies. OCME has historically provided excellent results with their work, but there are still improvements they can make. I would also like some updates on their gun crimes unit, which came into effect in December 2022. We see noticeable improvements with the gun crime cases turnaround due to this program and would like to learn more about the services provided. Once again, I would like to thank Chair Lee, along with my committee staff and my own staff for their work on preparing this hearing. I would also like to thank OCME for the work that they do. I will now turn it over to Dr. Graham for his opening remarks.
Good afternoon, Chair Schulman, Chair Lee, and members of the Committee on Health and the Committee on Mental Health, Disabilities, and Addiction. Thank you for the
Chief Medical Examiner, I'm sorry to interrupt you, but we do need to swear you in. Please raise your right hand. Do you swear to tell the truth, the whole truth, and to respond honestly to council member questions?
I do.
Yes, thank you. You can continue.
Thank you. Thank you for the opportunity to testify here today. We at the Office of Chief Medical Examiner value your leadership and thank the City Council for its partnership and support of our mission to serve the people of New York City. My name is Dr. Jason Graham, and I'm the Chief Medical Examiner for New York City. Attending with me from the Office of Chief Medical Examiner, or the OCME, are to my right, Robert Van Pelt, our Chief of Staff, and to my left, Yvonne Williams, our Deputy Commissioner of Administration and Finance. The OCME has two mission-critical roles: to protect public health and to serve impartial justice through forensic science and medicine. Our agency's core purpose is to provide answers in support of families and communities during times of profound need. Today, I'm fortunate to lead the nation's finest forensic medical legal institution, impartial, immune from undue influence, and as accurate as humanly possible, qualities that go to the core of why we exist and upon which the integrity of our science relies. I'd like